hospital and has over 25 years of experience on health sector. Thank you both for being with us today. With that, I now hand over the session to our esteemed chairs who will guide us through the presentation and discussion ahead. Thank you.
ल खाना पछिको सेसन एकदमै महत्त्वपूर्ण हेल्थ इक्विटिज एन्ड सोशल डेभलपमेन्टको कन्सेप्ट नेपाली समाजमा कस्तो कस्तो इनिक्विटिजहरू छन् र त्यो इनिक्विटिजलाई पूर्ण भत्काउन के गर्नुपर्छ भनेर हाम्रो एकदमै विद्वान प्रस्तुताहरूले आफ्ना कार्यपत्रहरू प्रस्तुत गर्नुहुनेछ। तपाईहरु सबैलाई स्वागत छ। हामी 9 मिनेटमा सक्ने कोसिस गरौँ। सबै प्रस्तुताहरूलाई अलिकति समय भयो भने हामी छलफल गरौँला महत्त्वपूर्ण कुराहरू यो भन्दै म आफ्नो केही भनाइ राख्दिनुहुन्न म्याडम चेयरलाई रिक्वेस्ट गर्छु।
Thank you, sir. We have total of 10 presentation today on the topic of health inequity and social development. So we can proceed now.
Thank you. So I would like to invite Preju Kandle, who is a MPH graduate from Patan Academy of Health Sciences, the recipient of Dr. Harka Gurung New Era Fellowship for the thesis research. I would like to invite other presenter to come and sit in the front row. Preju Kandle, please. IT. IT को साथीहरूले यो टेक्निकल पार्ट हेर्दिनु होला। हामीसँग समय छैन, त्यही भावनाले एकदम चुस्त दुस्त भइदिनु पर्यो IT को साथीहरू पनि।
Good afternoon, everyone. I am Preju Kandle, MPH student at Patan Academy of Health Sciences, and I will be presenting the findings of my study on the topic, Role of Commercial Determinants of Health in Use of Alcohol in Nepal, and it is a qualitative study. So I would like to begin the presentation with the introduction of commercial determinant of health. So any kind of activity that is done by private sector and the activities that affects people's health, whether it affects people's health in positive way or negative way. If it affects health and if it is a private sector activity, it is known as commercial determinant of health. And commercial determinant of health affects various risk factors and health outcomes, and I have selected alcohol use for my research. These are my study objectives. The general objective was to explore the role of commercial determinants of health in use of alcohol in Nepal. It was a qualitative study, and I took 28 key informant interviews from various bodies. The interviews were taken from 14 government bodies, 7 representatives from civil society, and 7 representatives from alcohol businesses, beginning from the producers at industry level to the retail sellers. And the interviews were transcribed, and I did coding using the software RQDA. And framework analysis was done using this analytical framework, which was given by a Lancet series that was published in 2023. So this framework has been categorized into 2 major parts. So the upper circle is commercial sector practices, which consist of 7 different commercial sector practices. And it includes the activities that commercial sector, so alcohol industry in our case, the activities those commercial sector do to influence people to consume their product and to harm people. And the semicircle below, it represents the determinant of health subsystem, which is about how our system interacts with those commercial sector practices. So our system sometimes our system gets affected by those practices, while sometimes our system tries to control those practices. So the first section comprised of 7 themes, and the second section had 5 themes. First theme is political practices. So what I found was there is high political influence of alcohol industries. So the industries are involved in policy making. They try to influence policies, and they even try to threaten people. So what I found was the consumer rights activists were threatened for speaking against alcohol industries, and even a parliamentarian I interviewed agreed to it. The second theme was scientific practices. So it is about how these industries portray their product. So the alcohol industries were found to portray their product as good to health. So one of the representatives from an alcohol industry said, even though they could not deny that alcohol causes harm to health, but they still said a healthy person must drink 1 peg every day. So these kind of practices create some confusion about the product to human health. And even people from other bodies also say that alcohol is not as toxic as tobacco, or it is not so toxic to human health. Another theme is marketing practices. It includes the practices these industries do to promote their products, to advertise their products, and to increase the sales of their product. So we all know how alcohol industries have been involved in supporting sports activities. And one of the interesting verbatim is that NHRC had conducted one program, and the teas were served in tea mats where the brand name of alcohol was written. And the next theme was supply chain and management practices, which is about how the industries manage the supply chain throughout the production till it reaches consumers, and about the waste management. And what I found was there is no proper sustainable kind of plan for the management of waste, including waste bottles. And this is the supply chain, and throughout this supply chain, marketing practices take place at every stage. Another theme is labor and employment practices, which is about how these industries manage their workers. And even though the industries' representatives claim that they manage their workers' health in a good way, but the representatives from other bodies were not so sure about the labor management practices in the industries. Another theme is financial practices, and which is about the way these industries try to obtain profit. So our government has employed very strict regulations in case of financial practices in alcohol industries to avoid the fraud practices, but they still cannot ensure that the compliance is 100% among all the industries. And this is the last theme of the first chapter of finding, which is reputational management practices, and it is about the practices these industries do to create good reputation among people. So sometimes they fund various programs, sometimes they even fund in schools or hospitals in health programs. And one of the health journalists said that a journalist wedding was organized by an alcohol industry so that the journalist does not speak against them or does not write against them. So moving on to second chapter of my findings, the first theme was politico-economic system. So this is about the overall system which influences how our policies are formulated, and the study participants shared about how our state prioritizes finances over public health. So the industries have huge financial contributions, they have contributed to employment opportunities, and so which is why our state has been prioritizing them over public health. The next theme is sectoral public policies, which is about the existing policies, and the study participants seemed quite dissatisfied with the existing policies because, for example, talking about Liquor Act, it is not formulated from public health perspective, but it has prioritized revenue perspective more than public health. Another theme was environmental factors. So it is about the environmental factors such as availability of alcohol or existing restrictions or acceptance of alcohol in society. So talking about acceptance of alcohol in society, alcohol is commonly presented in songs or comedy shows, or in various ways we have been accepting alcohol. So for example, if there is no such place where a person is restricted to enter if they consume alcohol. For example, if a person who is drunk or intoxicated tries to enter this program, I don't think they will be, we will not let them enter the program. Another theme is individual factors. It is about the individual characteristics of a person that leads to their different choices, such as they might have choices of different brands or their age, their sex, different factors. And the last theme of this second part is impact. So the participants talked about health impact, socio-cultural impact, so financial impact, and they even said that even though the industries have made a huge contribution to our finances, that might not be equivalent to the health loss they have been doing. So I tried to summarize those, all those practices in this figure of the second chapter. And moving on to conclusion, the participants agreed that there exists the role of commercial determinant of health in use of alcohol in Nepal, and they could not deny the effect of alcohol in human health. And the findings reveal that there is a huge policy gap and a need of strict policy implementation. And I would like to end my presentation with this message by the Director General of WHO. It is time for a paradigm shift. Public health cannot and will not improve without action on the commercial determinant of health from the local to global level. New forms of public health governance are needed. And if you want to know more about my research, I have put my email on this slide. And if you have any questions, I would be happy to answer them after the end of this session. Thank you.
Thank you, Ms. Preju. Yeah. Now we have next presenter. I would like to introduce him and be prepared for the presentation. Next presenter is Mr. Achyut Raj Pandey. He is a public health professional with over a decade of experience in health system research. He is a PhD research fellow at the University of Bergen and serves as the executive board of the NHRC, which is Nepal Health Economic Association. You can proceed now.
Hello, okay. I'm Achyut Raj Pandey, Bergen Center for Ethics and Priority Setting in Health, University of Bergen सँग आबद्ध छु primarily. साथसाथै हर्ड इन्टरनेसनलमा पनि म कार्यरत छु. आज मैले प्रेजेन्ट गर्न खोजेको चाहिँ मेरो PhD रिसर्च हो, Poverty and Intersecting Inequities in Access to and Utilization of Health Services, Insights from Nationally Representative Survey भनेर छ. म सिधै प्रेजेन्टेसनतिर लागेँ. आजको प्रेजेन्टेसनमा मैले सबैभन्दा पहिला ब्याकग्राउन्डको बारेमा डिल गर्छु, त्यसपछि अब्जेक्टिभ, मेथड्स, रिजल्ट्स हुँदै कन्क्लुजनसँगै प्रेजेन्टेसनलाई ऱ्याप अप गर्ने प्लान छ. अब यो ब्याकग्राउन्डको कुरा गर्दा किन इक्विटी इम्पोर्टेन्ट भयो भन्ने कुरा चाहिँ हामीले इक्विटीलाई तीनटा स्टेजेसमा हेर्न सक्छौँ. पहिलो चाहिँ इनइक्विटिज एन्ड एक्सेस टु सर्भिसेस. एक्सेसमै इनइक्विटिज हुनसक्छ, त्यो एक्सेसमै इनइक्विटिजले फेरि युटिलाइजेसनमा पनि इनइक्विटिज क्रिएट गर्छ, त्यसको चाहिँ इम्प्याक्ट अथवा आउटकम लेभलसम्म पुग्न सक्छ. अनि यो ट्रान्जिसन कस्तो हुन्छ भनेर हेर्ने भने इनइक्विटिज एन्ड एक्सेसको रिफ्लेक्सन चाहिँ इनइक्विटिज एन्ड युटिलाइजेसनमा देखिन्छ. जस्तो तपाईँले अहिले पब्लिस्ड आर्टिकल्सहरू हेर्दाखेरि हामीले 108वटा स्टडिजहरूमध्ये 77% स्टडिजमा चाहिँ डिस्टेन्स डिके इफेक्ट देखिएको छ. त्यो भनेको मतलब हेल्थ फेसिलिटीबाट मान्छे जति टाढा बसिरहेको छ उसको सर्भिस युटिलाइजेसन प्रोबेबिलिटी त्यो अनुसार घट्दै जान्छ भन्ने देखिन्छ. सर्भिस युटिलाइजेसनको सिधा इम्प्याक्ट फेरि हेल्थ आउटकममा देखिने भयो, हेल्थ इम्प्याक्टमा देखिने भयो. जस्तो यहाँनिर हामीले हेऱ्यौँ भने सब अप्टिमल सर्भिस युटिलाइजेसनको इम्प्याक्ट कस्तो छ भन्दाखेरि हामीले 2030 सम्म 27,116 न्युबर्न डेथ्स, 26,424 स्टिल बर्थ चाहिँ सब अप्टिमल सर्भिस युटिलाइजेसनले गर्दा हुन्छ, जसलाई चाहिँ हामीले अप्टिमल सर्भिस युटिलाइजेसन गर्न साथ प्रिभेन्ट गर्न सक्थ्यौँ. अब यो यसलाई फर्दर हेर्दाखेरि चाहिँ इच स्टेजमा इनइक्विटिजहरू कस्तो छ त मेरो प्राइमरी फोकस चाहिँ वेल्थ बेस्ड इनइक्विटिज हो. त्यो कारणले गर्दाखेरि मैले यहाँनिर अलिकति वेल्थलाई फोकस गरेको छु. अब यहाँनिर जस्तो लोएस्ट वेल्थ क्विन्टलमा 66% पार्टिसिपेन्टको लागि चाहिँ डिस्टेन्स प्रब्लमका रूपमा देखिन्छ. सर्भिस युटिलाइजेसनमा डिस्टेन्स प्रब्लम हो है भन्ने देखिन्छ भने त्यो प्रोपोर्सन जम्मा 13% छ रिचेस्ट क्विन्टल पार्टिसिपेन्टमा। भनेको यो रिचेस्ट र पुअरेस्ट क्विन्टल पार्टिसिपेन्टमा डिस्टेन्स कति ब्यारियर छ त भन्ने क्रममा चाहिँ 5 फोल्ड्सको डिफ्रेन्स देखिन्छ। त्यसपछि यो सर्भिस युटिलाइजेसनको कुरा गर्दा एउटा भेरिएबललाई हामीले पिक गरेका थियौँ, त्यो भेरिएबल चाहिँ हेल्थ फेसिलिटी डेलिभरी हो। हेल्थ फेसिलिटी डेलिभरीमा पनि 65% पुअरेस्ट 12 क्विन्टलको पार्टिसिपेन्टले हेल्थ फेसिलिटीमा डेलिभर गरिरहनु भएको छ, जबकि त्यो रिचेस्ट क्विन्टल पार्टिसिपेन्टमा 97% छ, 32 पर्सेन्टेज पोइन्ट्सको डिफ्रेन्सेस हो। र न्युनेटल मोर्टालिटी रेट हेर्ने हो भने पुअरेस्ट क्विन्टल पार्टिसिपेन्टमा 26/1000 लाइफ बर्थ छ, रिचेस्ट क्विन्टल पार्टिसिपेन्टमा 13/1000 लाइफ बर्थ छ, अलमोस्ट डबलको डिफ्रेन्स भयो। अब यहाँनिर वेल्थ क्विन्टलको मात्र यत्रो धेरै इम्प्याक्ट देखिन्छ भने वाट इफ अदर मल्टिपल फ्याक्टर्स आर कम्बाइन्ड, यदि त्यो चाहिँ अन्डर प्रिभिलेज्ड प्रोभिन्सबाट परेको छ अथवा रुरल सेटिङबाट परेको छ, एउटा इथनिक प्रोभिन्स पनि पछाडि परेको जस्तो कर्णालीबाट छ, पुवर पनि छ, रुरल सेटिङमा पनि बसिरहेको छ भने के हुन्छ त भन्ने चाहिँ हाम्रो मेन अब्जेक्टिभ थियो। त्यसलाई चाहिँ हामीले एसेस गर्न खोजेका छौँ। टु फोल्ड्स अब्जेक्टिभ्समा हेर्दाखेरि हामीले यो एक्सेस र युटिलाइजेसन, प्रोभिन्स, पोभर्टी स्ट्याटस र अर्बन रुरल सेटिङ अनुसार कसरी फरक पर्छ भन्ने एउटा अब्जेक्टिभ हो। अर्को अब्जेक्टिभ चाहिँ यो 3टा फ्याक्टर्सहरू कसरी इन्टरेक्ट गर्छ र त्यसले सर्भिसको एक्सेस र युटिलाइजेसनलाई कसरी डिटरमाइन गर्छ भन्ने चाहिँ सेकेन्ड अब्जेक्टिभ हो हाम्रो। यो हामीले डेटा एनालाइसिस चाहिँ नेपाल लिभिङ स्ट्यान्डर्ड सर्वे 2022 को डेटा एनालाइसिस गरेका थियौँ। यसमा चाहिँ नेसनल स्ट्याटिस्टिक्स अफिसले गर्ने सर्वे हो। 9600 हाउसहोल्ड्स रिक्रुट भएको थियो, 800 प्राइमेरी स्याम्पलिङ युनिट्सबाट, इच प्राइमेरी स्याम्पलिङ युनिटबाट 12वटा हाउसहोल्ड्सहरू रिक्रुट भएको थियो। अब म्याथोलोजीको कुरा गर्दा मैले म्याथोलोजीमा धेरै उसमा गरिनँ, यो स्ट्यान्डर्डाइज्ड वर्ल्ड ब्याङ्कको लिभिङ स्ट्यान्डर्ड मेजरमेन्ट सर्वे म्याथोलोजी प्रयोग भएको थियो र हामीले यो स्टडीको लागि चाहिँ डेटा म्यानेजमेन्टमा डिस्क्रिप्टिभ कुराहरू पर्सेन्टेज र मिनमा प्रेजेन्ट गरेका छौँ भने इन्फ्लुएन्सियल एनालिसिसहरू, लोजिस्टिक रिग्रेसन लगाइएको छ। यो आउटकम भेरिएबलमा एक्सेस टु सर्भिसेस विदिन 30 मिनट्स अफ वकिङ डिस्टेन्स भनेर राखेको छ, त्यो पनि पब्लिक हेल्थ फेसिलिटिज अथवा गभर्मेन्ट हेल्थ फेसिलिटिजको मात्रै यहाँ म आज प्रेजेन्ट गर्छु। अनि अर्को चाहिँ सेल्फ रिपोर्टेड एडिक्वेसी अफ हेल्थ सर्भिस युटिलाइजेसन हो। र इन्टरसेक्टिङ भेरिएबल्समा प्रोभिन्स, पोभर्टी र अर्बन रुरल सेटिङ छ। अब प्रोभिन्स र अर्बन रुरल सेटिङ खासै सायद हाम्रो स्ट्यान्डर्ड क्लासिफिकेसन भएको भएर मैले डिल गर्नु पर्दैन। पोभर्टीलाई चाहिँ हामीले कसरी डिफाइन गऱ्यौँ भन्ने कुरा मात्रै म ब्रिफली डिल गर्छु। त्यो चाहिँ एनुअल कन्जम्सन 72,908 पर क्यापिटा भन्दा कम मात्रै कन्जम्सन गर्न सक्ने क्यापेसिटी भएको मान्छेलाई चाहिँ हामीले पुअर भनेर क्लासिफाई गरेका छौँ। यो नेपाल लिभिङ स्ट्यान्डर्ड सर्वे 2022-23 को डेफिनेसन हो। यो ब्रिफ रिजल्ट्सहरूलाई प्रोभिन्स वाइज प्रेजेन्ट गर्दाखेरि यहाँनिर के देखिन्छ भने एक्सेसको हिसाबले पनि युटिलाइजेसनको हिसाबले पनि सबैभन्दा पछाडि चाहिँ एज ए स्ट्यान्ड एलोन हेर्ने हो भने कर्णाली प्रोभिन्स छ। त्यहाँ 30 मिनट्सभित्र पब्लिक हेल्थ फेसिलिटिजमा पुग्ने पपुलेसन 63% छ भने एडिक्वेटली सर्भिस युटिलाइज गरेको पपुलेसन चाहिँ 73% छ। एडिक्वेसी अफ सर्भिस युटिलाइजेसन हेर्ने हो भने बागमती प्रोभिन्स सबैभन्दा अगाडि देखिन्छ। मैले यो स्लाइडमा यति नै भने अहिले यहाँनिर अर्बन रुरल, रिच र पुअर बिचको कम्पेरिजन गरेर हेर्ने हो भने यहाँनिर अर्बन रुरल सेटिङ र रिच र पुअर बिच पनि नोटेबल डिफ्रेन्सेस देखिन्छ। जस्तो अर्बन सेटिङमा विदिन 30 मिनट्स हेल्थ फेसिलिटीमा पुग्ने पपुलेसन 86% छ, रुरल सेटिङमा 65% मात्रै छ। त्यस्तै गरेर रिच र पुअर कम्पेरिजन गर्दाखेरि 30 मिनट्सभित्र हेल्थ फेसिलिटिजमा पुग्ने पपुलेसन 82% छ, पुअरमा चाहिँ 68% पपुलेसन मात्रै त्यसरी पुगिरहेको छ। अब यो भेरिएबल्सहरूको इन्टरसेक्सन कस्तो देखिन्छ त भनेर हामीले हेऱ्यौँ भने चाहिँ हामीले अलिकति जनरली स्ट्यान्ड एलोन एउटा भेरिएबललाई कन्सिडर गर्दाखेरि देख्ने फिगर भन्दा कम्प्लिटली डिफ्रेन्ट फिगर्सहरू देखिन्छ। जस्तो एक्सेसको हिसाबले सबैभन्दा बेटर पोजिसनमा को छ भन्ने हो भने लुम्बिनी प्रोभिन्सको अर्बन सेटिङमा बसिरहेको पार्टिसिपेन्ट्सहरू छ। सबैभन्दा पछाडिको छ भन्दाखेरि बागमतीको रुरल सेटिङको पार्टिसिपेन्ट्सहरू छ, जुन चाहिँ कर्णाली सुदूरपश्चिमभन्दा पछाडि परेको छ। तर प्रोभिन्सको मात्रै हेर्ने हो भने बागमती प्रोभिन्समा 86% पपुलेसन विदिन 30 मिनट्स हेल्थ फेसिलिटीमा पुग्छ र रुरलमा 65% छ। यो इन्टरसेक्सन गर्दाखेरि त्यो प्रोपोर्सन अझ घटेको देखिन्छ। तर सर्भिस युटिलाइजेसनको कुरा हेर्दाखेरि सबैभन्दा धेरै एडिक्वेटली सर्भिस युटिलाइज गर्ने पपुलेसन चाहिँ यो बागमतीको अर्बन पपुलेसन हो। बागमतीको रुरल पपुलेसन पनि अलिक धेरै नै पछाडि देखिन्छ र कर्णालीको रुरल पपुलेसन चाहिँ सबैभन्दा कम एडिक्वेट सर्भिस युटिलाइजेसन स्ट्याटस भएको पपुलेसन देखिन्छ। यहाँनिर चाहिँ एउटा इन्ट्रेस्टिङ कुराहरू के हुनसक्छ भने बागमतीको रुरल पपुलेसन किन पछाडि पर्यो भन्ने क्वेसन चाहिँ आइरहेको हुन्छ, कतै स्याम्पल साइजले पो हो कि। यहाँनिर मैले मेथोलोजिकल क्ल्यारिटीको लागि त्यो स्टेट गरिहालेँ। लिभिङ स्ट्यान्डर्ड सर्वे मेथोलोजीमा चाहिँ प्रोभिन्स र अर्बन रुरल सेटिङलाई नै कन्सिडर गरेर स्याम्पलिङ स्टडी चाहिँ डिजाइन गरिएको हुन्छ। 15वटा एनालाइटिकल डोमेन्समा यो प्रोभिन्स र अर्बन रुरल सेटिङ कन्सिडर गरेको भएर यो इस्यु चाहिँ स्याम्पलको इस्यु होइन है भन्ने देखिन्छ। स्लाइड चेन्ज हुँदैन। ओके अब यहाँनिर यो लोजिस्टिक रिग्रेसनको फाइन्डिङ्स हो यसमा मैले धेरै डिल गरिनँ किन भन्दाखेरि अगाडिपट्टिको डिस्क्रिप्टिभ फाइन्डिङ्समा जुन कुराहरू छ लगभग त्यही कुराहरू यहाँनिर रेप्लिकेट भएको छ बागमतीको अर्बन पपुलेसनलाई रेफरेन्स मान्ने हो भने रुरल पपुलेसनको 87% लोअर अर्थ छ रिचिङ हेल्थ फेसिलिटी विदिन 30 मिनट्स अफ ट्राभल टाइम त्यस्तै गरेर यो एडुकेसी अफ सर्भिस युटिलाइजेसन हेर्ने हो भने बागमतीको अर्बन पपुलेसनलाई रेफरेन्स मान्दाखेरि कोसीको रुरल पपुलेसन र कर्णालीको रुरल पपुलेसन 78% लोअर अर्थ छ भनेपछि कोसीको रुरल र कर्णालीको रुरल पपुलेसन समट कम्पेरेबल जस्तो देखिन्छ अगाडिपट्टिको डिस्क्रिप्टिभ फाइन्डिङ्समा पनि यसमा पनि अब यो चाहिँ प्रोभिन्स र अर्बन रुरल सेटिङको कुरा भयो अब प्रोभिन्स र पुवर नन पुवर पपुलेसन क्लासिफाई गर्ने हो भने हेल्थ फेसिलिटीको एक्सेसको कुरा गर्दाखेरि मधेसको नन पुवर पपुलेसन चाहिँ विदिन 30 मिनट्स हेल्थ फेसिलिटीमा धेरै पुग्ने गरेको देखिन्छ भने कर्णालीको पुवर पपुलेसन चाहिँ त्यो प्रपोर्सन सबैभन्दा कम छ त्यस्तै गरेर एडुकेसी अफ हेल्थ सर्भिस युटिलाइजेसनलाई प्रोभिन्स र अर्बन रुरल सेटिङ के अरे पोभर्टी स्ट्याटसको इन्टरसेक्सन हेर्ने हो भने बागमतीको नन पुवर पपुलेसनले सबैभन्दा एडुकेट सर्भिस युटिलाइजेसन गरेको देखिन्छ भने मधेसको पुवर पपुलेसन सबैभन्दा पछाडि छ जुन मधेसको पुवर पपुलेसन भनेको सुदूरपश्चिमको पुवर कर्णालीको पुवर कोसीको पुवर मधेसको पुवर समट कम्पेरेबल छ त्यसै टार्गेटेड इन्टरभेन्सन्स गर्ने हो भने समट यो चारवटै स्टाटाहरू समट कम्पेरेबल अथवा टार्गेटेड इन्टरभेन्सनको लागि योग्य हो कि भन्नेको जस्तो देखिन्छ त्यही कुरालाई हामीले लोजिस्टिक रिग्रेसनबाट हेर्दाखेरि बागमतीको नन पुवर पपुलेसनलाई रेफरेन्स मान्दा कर्णालीको पुवर पपुलेसन 80% लोअर अर्थ देखिन्छ कोसीको रुरल 78% लोअर अर्थमा देखिन्छ त्यस्तै गरेर बागमतीको नन पुवर पपुलेसनलाई रेफरेन्स मान्ने हो भने एडुकेसी अफ सर्भिस युटिलाइजेसन स्ट्याटस हेर्दाखेरि मधेसको पुवर पपुलेसन 91% लोअर अर्थ देखिन्छ जुन चाहिँ धेरै डिफ्रेन्स छ भन्ने किसिमको एउटा क्रुड रिफ्लेक्सन भयो यहाँनिर चाहिँ हामीले प्रोभिन्स अर्बन रुरल सेटिङ र पोभर्टी स्ट्याटस तिनटैको इन्टरसेक्सन भयो भने के हुन्छ भन्ने हिसाबले हेऱ्यौँ तिनटैको इन्टरसेक्सन हुँदाखेरि लुम्बिनीको अर्बन सेटिङमा बसेको नन पुवर पपुलेसन एक्सिसको हिसाबले गर्दा हेर्दाखेरि विदिन 30 मिनट्स ट्राभल टाइमभित्र हेल्थ फेसिलिटीमा पुग्न सक्ने पोजिसनमा सबैभन्दा राम्रो अवस्थामा देखिन्छ भने बागमतीको रुरल पुवर पपुलेसन सबैभन्दा पछाडि देखिन्छ जुन चाहिँ गण्डकी कोशी सुदूरपश्चिमको रुरल पुवर पपुलेसनसँग कम्पेरेबल भयो एक्सिस एडुकेसी अफ सर्भिस युटिलाइजेसनको कुरा गर्दाखेरि बागमतीको अर्बन नन पुवर पपुलेसन सबैभन्दा बेटर पोजिसनमा देखिन्छ त्यस्तै गरेर कोशीको रुरल पुवर पपुलेसन सबैभन्दा कमजोर अवस्थामा देखिन्छ यो सिमिलर फाइन्डिङ्स छ यसलाई मैले अलिकति स्किप गरेँ कन्क्लुजन्समा जाँदाखेरि के देखिन्छ भने जस्तो हामीले इनेक्विटिजहरू हामीले प्रोभिन्सको हिसाबले कम्पेयर गऱ्यौँ अर्बन रुरल सेटिङको हिसाबले कम्पेयर गऱ्यौँ अथवा पोभर्टी स्ट्याटसको अनुसार कम्पेयर गऱ्यौँ भने त्यो तिनटाको इन्टरसेक्सन हेर्दाखेरि त्यो इनेक्विटिजहरू अझ सिभियर लेभलमा पुग्दो रहेछ भन्ने देखिन्छ त्यहाँ 3 फोल्ड्स डिफ्रेन्सेससम्म देखिन्छ हाम्रो पोलिसी कमिटमेन्ट चाहिँ हाफ एन आवरभित्र पपुलेसन चाहिँ हेल्थ फेसिलिटीमा पुग्नुपर्छ भन्ने हुँदाहुँदै अलमोस्ट हाफ अफ द पपुलेसन इन रुरल सेटिङ अफ 4 प्रोभिन्सेस चाहिँ त्यहाँ पुगेको देखिँदैन यो यसको क्रुड रिफ्लेक्सन चाहिँ एउटा रफ रिफ्लेक्सन चाहिँ यो ब्ल्याङ्केट एप्रोचमा हेल्थ फेसिलिटिजहरू एक्सपान्ड गर्ने र सर्भिसलाई स्केल अप गर्ने स्ट्राटेजी चाहिँ इफेक्टिभ हुँदैन कि किनभने बागमतीको रुरल पुवर पपुलेसन चाहिँ कर्णालीको पुवर पपुलेसनसँग कम्पेरेबल छ भनेपछि त्यो स्ट्राटेजी अलिकति रिथिङ गर्नुपर्छ कि भन्ने एउटा म्यासेज हो टेक होम म्यासेजमा मैले दुईवटा मात्रै गरेको छु एउटा चाहिँ एउटा फ्याक्टर एकचोटिमा मात्रै कन्सिडर गरेर डिसिसन मेकिङ गर्दा कहिलेकाहीँ अलिकति मिसलिडिङ कन्क्लुजनमा हामी पुग्न सक्छौँ अर्को कुरा चाहिँ अघि भने जस्तो ब्ल्याङ्केट एप्रोचबाट हेल्थ फेसिलिटी एक्सपान्सन गर्नु चाहिँ उपयुक्त नहुन सक्छ हाम्रो कन्टेक्स्टमा
थ्याङ्क यू अच्युत राज पाण्डेजीको प्रेजेन्टेसन सुनौँ जस्तो लाग्छ तर समयले फेरि हामीलाई 9-10 मिनटभन्दा अगाडि जान पाइन्न भनिरहेछ धेरै धेरै धन्यवाद नाउ आई वुड लाइक टु इन्भाइट सितास्मा मैनाली सी इज अ पब्लिक हेल्थ ग्रेजुएट फ्रम पोखरा युनिभर्सिटी वर्क्स अन कोरस project at HUD International focused on urban health system. Over to you, Sitasma Mainali.
Namaste and a very warm good afternoon, honorable chairs, my fellow presenters and everyone present here.
यो आईटी को साथीहरुले अलिकति आईटी को साथीहरुलाई के लाग्छ भने मैले जानेपछि सबैले जानिहाल्छन् जस्तो लाग्छ हुँदैन है जिन्दगीमा त्यस्तो त्यही भएर अलिकति ख्याल गर्दिनु होला
Sorry. Good afternoon, everyone present here. Good afternoon, Honorable Chair, everyone present here. Sorry for the technical delays. I am Sitashma Mainali in front of you all, and I would like to present today on the topic Urban Health and Equity in Nepal, Analyzing Social Determinants, Disease Prevalence, and Health Outcomes. Before beginning this presentation, I would like to thank the organizing committee for bringing us all together for this important summit. And I would also want to acknowledge my study team for their contribution to this study. Urban Health Equity in Nepal, Analyzing Social Determinants, Disease Prevalence, and Health Outcome is a part of our broader work under the Project Chorus. This is the outline of today's presentation. Talking about urbanization and equity concerns, we all know that Nepal is facing rapid urbanization in Nepal, and it is drivers that urban population in Nepal are facing well-developed infrastructures, access to essential services, technological advancement, and better environment. We can see that these all factors are sorry. These all factors takes us to inequities, and then the sectors which are affected are health, education, environment, and livelihood, safety, and culture. Talking about the background, there is rapid urbanization in recent decades in Nepal, with 66% of population living in urban areas projected to rise further, which takes us to inequities in healthcare, education, clean water, and various lacking opportunities. These all are the factors which leads us to socioeconomic determinants, overcrowding, limited access to limited healthcare access, and higher disease burden, which leads to dual burden of disease. Now, urban areas are facing both communicable and non-communicable diseases. The main objective of this study is to examine and compare the social determinants, health indicators, and disease burden across different municipalities, municipality types, urban areas, and poverty statuses in Nepal. We did a secondary data analysis and used all the 4 national reports, namely Nepal Demographic Health Survey, Nepal Housing Population Census, Nepal Living Standards Survey, STEP Survey. The data on social determinants, disease prevalence, and maternal child health outcomes were compiled into from the 4 national reports were compiled, and then cross-tabulation was done to compare between rural and urban areas, as well as Kathmandu Valley and other regions. Urbanization in Nepal, expansion to explosion. As we all know, Nepal urban areas continue to grow rapidly in Nepal. We can see both opportunities and challenges at the same time. Urban centers are now, from 1952, there were 10 urban areas, and now it has exploded to 293 in 2021 after federalism. We can see 66% of the urban population, 300% growth in urban population and household in just a decade. Urbanization and social stratification. This table highlights the social stratification across different residence types in Nepal. As we move from rural regions to the metropolitan to the urban areas, we can see a better literacy rate, ownership of household assets, improved sanitation facility, improved drinking water, use of electricity, and better clean cooking fuel. But we can see that active employment rate in rural areas is higher than urban municipality with 47.3%. Urban poverty, demographic, and provincial outlook. We can see that 58.9% of the population residing in the urban regions are poor. 66.5% of the people residing in the urban regions fall in the poor distribution. 56.7% of the urban poor are literate, while only 26.8% of them are employed. We can see the provincial bar here, where higher concentration of urban population are found in Madhya province, followed by Lumbini, Koshi, and Sudir Paschim. Urban clusters witnessing NCD prevalence. We can see that urban regions, particularly Kathmandu Valley, have higher prevalence of diabetes at 22.4% and heart condition at 5.8%. By wealth quintile, we can see that the richest group have the highest rates of diabetes at 14.7% and heart condition at 8%. On the right, we can see that NCD risk factors are significantly higher in the urban poor, while 26.9% have hypertension, and the urban poor are facing NCD risk behaviors, high disease burden, and mortality in the urban clusters. We can see that there is a high burden of NCD and CDs among the females. Urban areas outside Kathmandu Valley report higher rates for communicable disease. Highest burden of NCDs were by blood pressure in male and gastrointestinal disease in female poor. We can see that better outcomes in some of the indicators in the rural areas. 82.4% of the rural women attend 4 or more ANC visits compared to 79.5% in the rural areas, and 80.3% of the rural children aged 12 to 23 months are fully vaccinated compared to 79.8% in the urban areas. Across wealth quintile, we can see that the highest wealth quintile has the best outcomes, with 92.6% attending ANC visits. Stunting in children under 5 is higher in rural areas at 31%. We can see that in Kathmandu Valley, 34.9% prefer pharmacy for communicable disease compared to 40.2% in the urban settlements. For NCD, private hospitals are highly favored in Kathmandu Valley. Mean time taken to travel hits the stark difference, as it shows it takes 22.7 minutes to reach health facility in Kathmandu Valley, whereas it takes only 132.6 minutes in average from the rural areas. There is a huge difference between poor and non-poor, as it takes only 99.5% to reach government facilities from the poor, and the non-poors, they can reach government health facility at 64.3 minutes. To conclude, this study reveals significant disparities in health and socio-economic indicators across Nepal. Literacy, maternal and child health services, and NCD prevalence vary widely between metropolitan cities, sub-metropolitan cities, and rural areas. Urban areas have greater access to healthcare services. Rural areas face elevated rates of hypertension, limited access to maternal health services. So these findings underscores necessity of context-specific policies and strategies, resource allocation to address distinct health and socioeconomic challenges. The takeaway message, to really close these inequity gaps, we first need to identify and prioritize addressing systemic and preventable health inequities linked to social, economic, and environmental structures. Then, secondly, assess disparities in health outcomes that disproportionately affect marginalized people. Third, by ensuring that outcomes are clearly identified to target modifiable factors influencing health inequities. And finally, by enhancing the data collection systems to include equity variables, enabling the measurement and monitoring of progress, closing health inequity gaps. Thank you.
Thank you, Mr. Sitashma, to finish on time. Now I would like to invite the next presenter. Next presenter is Mr. Vikas Koirala, who is the PhD Fellow in Public Health at the University of Huddersfield, with more than 12 years of experience in health, nutrition, and disaster risk reductions. Okay, time is yours.
Good afternoon, everyone. Honorable Chairperson, scientist, health and population scientist, my team members, and all the public health professionals and researchers. I'm honored to be here and presenting some of my research findings on behalf of my team. And talking about the background of this research work, let's talk about the glorious Kathmandu Valley and beautiful Pokhara Valley, where everybody come and visit. People have affluent lives, but there is one strata of people who are often overshadowed by the lights and the beauty of the city. And this strata of people is the people of slum dwellers, or people, in a polite term we use the word people living in informal settlements, but we say Sukumbasi, squatters, slum dwellers or so. So we tried to find, my former colleague from Hard International presented quite an interesting fact about the prevalences of several aspects of urban poor, but we try to delve into the grassroots and try to find out the living conditions and the in-depth reality of the people living in those settlements using the participatory methods. I will not go much into the backgrounds. Just to iterate that South Asia has the highest rate of urban poor, including Nepal. And talking about the objective of this research, we try to investigate what is the living condition, what is the access to health services, and how the government or the stakeholders are looking into these people, what is the accountability of the government, as well as the other sectors, citizen society, to the people dwelling in such settlements. So let's look at this picture. We chose two sites. Actually, we wanted to go to a lot of sites to do this research work, but we found out that people living in the slums or squatter settlements are so much traumatized by the government or the system that they wouldn't allow anyone to enter because they are traumatized by the fact that they can be evicted anytime. So finally, we found some people who allowed us to go to their settlement and do some research. Let's look at this picture. We can see that one is just at Manohara, and all the ugly structure or non-beautiful structure is the structure where the dwellers, where the informal settlement is, because it is all just makeshift shelter, just mere tents made from the CGI seats. And the other side, in beautiful Pokhara Valley also, the river side, you can see this Goste Community Hall, there's something is written there. It is also the river side near Lama Chaur, where the people of the informal settlements they have nowhere to go, so they have just found some patch of land on the riverside, and they are settling there. And there have been some political saying that these people are not actually vulnerable. Some of them are not Hukumbasis, not Sukumbasis, but in fact we found out that some of them are Hukumbasis, but more than half of them are actually vulnerable people. So just wanted to show you these Google map images to you. And talking about our methodologies, we use stakeholder analysis, social mapping, and transit work. So all the findings we found was through the community-based participatory method. So the findings is found by the residents themselves. So these are the photos of the methods we used. Let's look at the results. Looking about the living conditions, except for a few buildings which were built in an unauthorized way using reinforced concrete structure, more than 80% of the buildings were just temporary housings and makeshift shelters just made out of CGI seats. And they are quite inadequate and disaster prone because they are vulnerable to floods, fires, and extreme weather conditions. In summer it's too hot, in the winter it's too cold. And people are like 6 to 10 people were sitting in the same room. That means there's a problem of overcrowding also, and which results in lack of basic services, no proper water supply, no proper toilet. It's just, and mostly open defecations and so. And environmental risks comes along like floods and monsoon rain, and which is all connected. So these people live in really dilapidated conditions. And talking about access to health services, first thing is they stay in a place which is not recognized by the government. That means they stay in an isolated places. There are no dedicated health services, so there is limited availability. And similarly, the people who definitely get sick, what we do is go to the pharmacy, we just ask for the medicine, and we have it. And if we are not too sick, we might just go to a traditional healer, Dhami Zakri, and just try to skip the formal channel. Similarly, there are financial barriers also. These people are already financially vulnerable, and they are often afraid to go to big hospitals, and that makes them spend a lot from the out of pocket going to pharmacies and doing the different kind of treatment. And similarly, one kind of vulnerability, like my previous colleague said, led to the other. That means they have the awareness gap also. They try to skip the things, and they, especially we have simple things like antenatal checks and all those things. Some people are slightly aware, some people are not aware at all, and so health awareness gap is also there. And there are some quotes. So one of the participants said us that there is a health post in the ward office. When they know that we are from this Sukumbasi Basti, they discriminate us, and but the shopkeeper, the pharmacist, the medical hall people, they respect us. So who goes there? I prefer going to the medicine shop. So such kind of quotes have come along. And talking about governance and accountability, I would like to summarize. I would not like to go in deep, but the government does not recognize them because they are unauthorized illegal settlers. That means only a few people who are there is some NGOs who are doing temporary things. We also try to do a few things, like try to set up a tap in Manara settlement, but after doing all the final work, we didn't get the line because the ward chairperson doesn't recognize it's the illegal land, there's no Lal Purja and all. And community participation in decision making is also lacking because these people are not recognized as the community people. That means governance and accountability is almost non-existent. Some, like Kathmandu, Pokhara Mahanagarpalika is trying to, it at least recognize and try to do a few things for the locals, but in Kathmandu it is almost non-existent. And so there are the few codes that we are not, nobody supports us and we are on our own. These kind of codes are there. So the conclusion is that we utilized well-known methods, research methods, and tried to find out in-depth understanding. And we went there, we found out, if you are the resident of Kathmandu Valley, you have definitely been there, we have heard about it, we know it, but we try to document it through research methods. And my upcoming colleague is also presenting another method in the same research. So everything is difficult except one thing in those settlements. That is, the people are not supported by anyone but by themselves. So the social network is quite strong. They have their own clubs. They are supporting themselves, but that's not sustainable. So the takeaway message is that somebody has to recognize them and have to support. And otherwise, these people who represent quite a large number of urban poor have been refugees in their own country. So let's do something about it. Let's do it from the policy level. So thank you very much. I would like to acknowledge UKRI and Arise Hub, Liverpool School of Tropical Medicine, and everyone who was involved. Thank you very much.
Thank you. Thank you, Vikas Koiralaji, for on time. Now I would like to invite Shitu Keshi, who is MPH and PhD in Health Sciences. She is the research lead at FACE Nepal. Her title is Life in Nepal's Informal Settlement, a photo-wise study on health, equity, and resilience. Shitu Keshi, over to you.
Thank you, sir. Respected chairs, distinguished ladies and gentlemen, a warm greeting to everyone. My previous colleague has already presented on the participatory method we have employed in this ARISE project, and in my presentation, Life in Informal Settlements of Nepal, a reflection from photo voice, I will be focusing on this photo voice method. Okay, going through the background, the global population, globally it is increasing and it is projected to be 70% by 2050. And in Nepal also, urbanization is rapidly increasing. Informal settlements in Nepal, it refers to areas where people have built houses on land without legal permission, lease or building permits, and usually without adhering to building and planning regulations. This study aimed to explore the status of living condition, access to basic services, and environmental risks among the people living in informal settlement in Kathmandu Valley. So we have selected 2 informal settlements from Kathmandu Valley, that is Namuna Basti and Manohara informal settlement. And we selected 18 participants through the help of our co-researchers we have identified for our ARISE projects, and they also include the most vulnerable populations like single women, people with disability, and also the people who are being involved in waste workers. So we employed the participatory method photo voice for this study. Photo voice is a participatory research method that empowers individuals, especially the marginalized groups, to document their lived experience through the photography and interviews. And photo voice is a very powerful research method these days to document the lived experience through the engagement of the community people, especially the marginalized and underrepresented population. And we have provided 2-day training for on the photography technique, ethical considerations, and fieldwork executions. They were provided a week time to capture pictures on the pre-identified themes, which were developed together discussing with the participants, and the photos were collected followed by the interviews. Photo collection was done in 3 rounds. We have asked the participants to bring as photos as much as possible relevant on our pre-identified themes, and they were asked to select the 5 key images that best represent their experience in depth. So I'll be presenting findings on these themes. So these are the photos taken by the participants themselves, and they express the photos and their experience through their narratives. So the first picture, this shows the housing condition of the informal settlement, and we can see that almost of the houses, they are made of zinc sheet, and there is no proper ventilation and insulation, and we can see these challenges here. And in the next photo, this is the temporarily built bridge by the community people, and they have been using this bridge for their transportation purpose, but during the monsoon, this bridge will be swept away, and people have to walk 30 minutes more to travel across the river for their daily purposes. And these are the livelihood challenges and the people using strategies for their living. Like in the first picture, 2 women, they are carrying sacks of sand from Manohara river, and they used to sell them for their livelihood. And in second picture, a man, he is rearing goats, and he has started a small hotel for his livelihood. And in third picture, a woman, she has started a small business with 1 sewing machine, and now she is able to provide employment for other 2 women from the informal settlements. So this is the another aspect of the livelihood, like employment opportunity is very scarce for the people of informal settlements, and they have been using their spare time in this kind of recreational activities which might increase the social problems and also increase the mental health issues. And I want to highlight the, like water is the very basic need of every people, but they need to struggle for drinking water every day. They need to have a queue at least 1 hour to fill a jar of drinking water. But community people, they have been resilient, like they have been using other sources, like there is a hand pump we can see here which is very old, and people are using water for other household purposes from there. And we can see in the next picture there are 2 tanks which has been provided, supported by an organization, and they used to fill those tanks from a tanker which will be so cheaper, more than 50% cheaper than they need to buy from a retail shop. And these pictures, they show the lack of health services. Like in the first picture, the woman is suffering from common cold and fever, but she is not getting health service care because health service care facility is not within the settlement and nearby. And if she need to go to nearby private clinics, then she cannot afford for that. And second, she is suffering from mental health, and she has also skin problems like burns and wounds, and she is not getting health care services yet. And this is, we can see here, small children, they are going to children, and this is a photo taken by one of the participants of Namuna Basti, and she has also children, and she is a single woman, and she thinks that if I could afford my children's education, then it will be a very happy moment for her, but unfortunately she cannot. And these are the cases of mental health issues, like the young man, he's suffering from mental health issues, and there are also other mental health issues very common in the settlements. And here is like unsafe structure, and a baby is approaching there. These kinds of unsafe structures within the settlements, this has been a great fear for the community people. And these are the instances of environmental risks, like we can see settlement has been situated on the river banks, and in the monsoon, every day they have to sleep in fear that tomorrow morning we will have our housing or our belongings, or we will be there or not. And second picture, it shows the most vulnerable condition of the housing we can see here, and still people are living there because they have no other choices. And this is the worst condition. We can see people are throwing garbages in the river, and this is the picture of one of the elderly couple's home, and they still cook here and have food because hygiene and cleanliness is beyond their necessities, because there is no one to take care of them, and they have to fulfill their stomach. So in conclusion, our findings highlights the need for inclusive urban planning, highlighting on the improved access to basic services and livelihood opportunities. And our study also provides insights for participatory approaches in public health research to identify the real needs of the marginalized and underrepresented population, and this will inform policymakers to ensure an equitable and sustainable urban development. And through this photo voice, we have prepared a photo book, and this has been published in Arise Consortium website. If you are interested, you can go through this in detail. So we'd like to acknowledge UKRI, Liverpool School of Tropical Medicines, and all the participants and co-researchers who have been involved throughout this research. And these are the references. This is me, and thank you.
Thank you. Thank you so much, Ms. Setu, for an interesting presentation. Now I would like to invite next presenter, who is Mr. Parasmani Sapkota, who is a public health official from Tribhuvan University, who has more than 2 years of experience in health system and quantitative research. Okay, floor is yours.
Hello. Thank you, ma'am, respected chairs, and everyone in the audience. My name is Parasmati Sapkota. I work as a data and research officer at HERD International, and presenting on behalf of my team is our research titled Determinants of Wealth-Related Inequalities in Mental Health, a decomposition analysis of nationally representative household survey data. So without further ado, moving towards a bit of background information. So mental health has been in a rising trend since the past decade, and it's forecasted to be the same. Mental health, particularly anxiety and depression, are affected by numerous socioeconomic variables, socio-demographic components that exacerbate their intensity as well as prevalence and distribution. Nepal, being low-income country, is marked by significant economic disparities, and these inequalities may intensify mental health issues. Investigating these issues is very critical to inform policies regarding those intersecting variables that are key to identifying these distributions. And Nepal Demographic and Health Survey 2022 provides this critical insights into these dynamics, having been the first iteration among many to include a mental health module in its core questionnaire. So the objectives of my research are to identify the determinants of wealth-related inequalities, quantify those socioeconomic disparities, and then decompose these inequalities to find the socioeconomic variables that contribute the most to these inequalities. So NDHS in its nature is cross-sectional. So the mental health module was implemented in a subsample of households selected for the mains interview. And although men and women eligible in the household were taking the total sample to 12,355. The outcome variable of our study is symptoms of anxiety or depression measured by GAD and PHQ scales with cutoff points of 5 and 9 respectively. We'll be measuring inequality based on concentration curves and relative concentration index. We'll be finding out the factors associated with them using a multivariable logistic regression, and we'll be decomposing that concentration index using a rigorous decomposition. So moving on to this classification that I'm putting in front of you. This is a classification done by the National Statistics Office on their degree of urbanization report. It classifies all the wards of Nepal into rural, peri-urban and urban areas. So what's the necessity of this classification compared to what's already there in the study? So what happens is NDHS employs a very umbrella approach to distinguish rural and urban areas. All the wards, all the clusters within an urban municipality and the rural municipalities are segregated urban and rural respectively. But that's not how it works. Urban population and urban areas are determined by numerous factors, and National Statistics Office incorporate all those factors such as population density, the build-up coverage areas, which means the structures in that residence, and those proximities of those components together. So effectively dividing all the wards into rural, peri-urban and urban areas. So our study tries something new. We attempted to link the degree of urbanization report with the DHS clusters to identify and divide all the DHS clusters into rural, peri-urban, urban areas, which is a more robust method as used previously in DHS. So how do we do that? So there is a method called as point-in-polygon method, most probable value approach, as given by Perez, Hedrick, et al. So what we do is firstly layer the ward level save files of Nepal with the degree of urbanization attribution, dividing it into rural, peri-urban, and urban areas. Then we plot the urban and rural clusters. I'm not quite sure if it's visible here, but the black one represents urban clusters and purple one represents rural clusters. So what DHS does is to maintain confidentiality. They offset all those cluster values into 2 kilometers and 5 kilometers offset to maintain that confidentiality. So what we do is build up buffer zones to adjust for that offset. Now what we do is create a program to actually find the most probable value using the probability method. So whatever the degree of urbanization attribution is in the ward level save files, the program extracts the most probable value of their clusters based on area it occupies. And you can see that in my previous slide, if I'm able to move back. So you can see that the NDHS classifies this cluster as urban, but you can see that according to the degree of urbanization report, it's nowhere near urban area. So that's one of the major drawbacks of major surveys that's happening in Nepal. They classify urban-rural categories in a very umbrella approach. So we tend to rectify that. So what the program did was classified all 476 clusters with an accurate prediction of 92%, and the rest 39% were recategorized based on further mathematical computations and visual inspection method. So you can see that after the classification, across all mental health outcomes and the severity, urban population had the greatest prevalence. And we can also see that it's widely prevalent of symptoms of anxiety and depression was the most in Karnali province, with least in Gandaki. And across wealth quintiles, you can see that it gradually decreases with increase in wealth status. So using Erriger's correction, we plotted the outcome variable symptoms of anxiety and depression against wealth rank. What this makes is a Lorenz curve with a line of equality in the middle. Anything that's above the line of equality says that the health outcome is pro-poor distribution in nature. So we can say that for both anxiety and depression cases, the outcome was pro-poor in distribution. When you look across all the residence type, you can also see that the most inequitably distributed was again in the urban population, followed by peri-urban and rural areas. So we also performed multivariable logistic regression methods to find the factors associated with mental health outcomes. And we found out that age, gender, marital status, and health status were varying in magnitude across all residence type. Youth age 15 to 24 were significantly higher, had significantly higher odds of experiencing anxiety or depression compared to those aged 35 to 49. And gender, across gender as well, men had consistently lower odds of experiencing these symptoms compared to women. So from the results of decomposition analysis, we found out that sex was the leading contributor to disparities in anxiety and depression symptoms, accounting for over 60% of all the variation across all residence type. So it basically states that being a male or a female would likely influence your probability of acquiring mental health problems. Similarly, internet use significantly influenced disparities in rural and urban areas, whereas marital status and occupation were notable factors in peri-urban areas. Education impact varied by setting, contributing positively in peri-urban areas, but negatively in rural and urban areas, reflecting that it's very much context specific. So the key conclusion and takeaway messages are, from all my results, it's quite clear that the proportion of mental health outcomes is pro-poor in distribution, and it's distributed more inequitably in urban areas. Sex, again, is the dominant driver of all these inequalities across all settings, and other factors like internet use and education varied by context. And what this suggests is addressing these disparities, particularly in urban areas with urban poor, requires a very strategic approach, looking at all those intersections and in a more robust method for equitable access to health and well-being. That will be all. Thank you for your patience.
Thank you, Parasmadiji. So now next speaker is Javindra Bhandari, who is a senior public health professional at the Central Department of Anthropology, Triveni University. He is an expert member of Ministry of Health and Population, specializing in health system research, inclusive governance, and medical anthropology. Over to you, Javindra Bhandari.
Thank you, sir. Respected chairs, Professor Madhu sir and Sangeeta madam, and all the audience and the presenters. First of all, I would like to thank for this opportunity. For this opportunity to present some of the perspectives from anthropology. As a student of public health, global health and health systems, and anthropology, basically, from yesterday, in all the presentations, most of the presentations, we have discussed about the equity issue, inclusion issue, diversity issues, and access issues. And we are talking about the universal health coverage and how to reach out or how to address the healthcare needs of those poor, socially excluded or marginalized populations. And we are also talking about the out-of-pocket expenditure and the poverty and all these things. Perhaps my presentation would add some values in terms of some of the perspectives that how health and illness narratives of people are correlated or linked to access to health. Is our health system, or from supply perspective, is also recognizing the health and illness narratives of the people on the ground. So, considering the time limitations, I would like to quickly go through my presentations. As we all know that a human health is predominantly guided by the biomedicine, but if we look at the, if we have some closer look at the healthcare access, healthcare systems, and all these things, but it is largely anchored in socio-cultural context. And our human history and civilization changes over time, so the context is changing, so our healthcare needs are also changing. Another important thing is that health and illness narratives are socially produced and locally grounded. And there is a clear need of some of the anthropological evidence in order to deepen our understanding on how health and illness narratives are socially embedded within and across cultures, within and across communities, within and across societies. And perhaps critical medical anthropology perspectives can fill in those gaps or the opportunities. This is a rapid scoping review of very relevant published literatures, articles, book chapters. And the purpose is the anthropological scholarship primarily aims to explore the larger sociocultural context, political, economic, historical context of the health and illness narratives in the local context. Here are some of the findings. Perhaps the understanding illness requires attention not only to the biomedical models, which is more dominant in our context, but also to the subjective experience of individuals who are ill or who are facing some sort of sickness or disease. These embodied experiences of people, which are largely culturally interpreted subjective experience of health or illness. More importantly, the embodied experiences are influenced and shaped by gender, age, social status, and access to healthcare. Perhaps this also demands some sort of our approach of intersectionality approach to see or to observe or to evaluate our healthcare system. The indigenous knowledge, beliefs, and the narratives of health and illness, once again, are shaped by differential dimensions of ecological, economic, social, cultural, and symbolic frameworks. And these all contribute to epidemiological transition. And these transitions are very important because the profiles of the diseases changes over time. Different communities face different sorts of the health and illness kind of profile. So our human health is the interplay between the culture, society, and health. Culture, norms, values, social relationships, societal structures, power dynamics, and inequality. All these contribute to how people access to healthcare. Or there is perhaps easy access to healthcare, but some of the contexts might constrain people's ability to access healthcare. I would like to remember Paul Farmer's the structural violence also here, how structural violence, our systems, structures can also enable or constrain access to healthcare. Local healthcare systems intersect with social, cultural, political, and economical conditions. In the federal context, for example, if we are talking about the local health systems, perhaps there is a kind of governmentality, because there are so many agencies, actors, and there are different structures at the local level, from the community, from the health facilities, political leaders, government officials, government structures, community institutions. There are certain structures and how those structures govern the healthcare delivery. Perhaps within it, it is also important to see the power dynamics and the agency of the communities to overcome the barriers, whatever they are feeling about it. Perhaps the anthropological perspectives also help bridge how local healthcare systems are leading to the global health policies and how global health policies are also affecting or influencing our local health policies. Perhaps this is a two-way process. In this context, critical medical anthropology offers a comprehensive framework that explores how social, economic, and political structures, once again, influence health outcomes. And medical pluralism can define and redefine the health and illness narratives within and across different social groups. Because we are talking about the ethnic minorities, indigenous people, socially excluded people, mobile people. So there are different populations who are equally or unequally vulnerable to, in terms of health status. The conclusions are there needs a holistic study of human conditions as it relates to health and illness in the larger framework of social, cultural, behavioral, biological, psychological, and historical context. Whenever local health policies or provincial health policies or even federal health policies, if they are formulated or if they are, developed, I mean, we need to consider the larger context. Health and illness relies on social differences because we are talking about social inequalities. There are borders, there are boundaries, there are limitations. One of the observations we can see the health outcomes, health indicators. I mean, there are inequalities across provinces, and there are inequalities in terms of health outcomes across local governments also. But why this is happening? Perhaps anthropology can also bridge in or evaluate on that, having these equity issues or inequity issues, access issues, marginalization issues. So there is a clear need to explore the scope and relevance of CME, I mean the critical medical anthropology, in terms of its potential contributions in health system governance research. Having said this, only 1 minute, sir, is it possible? Only 1 minute. Okay. Thank you. I think the paradigm is shifting because we talk about the social determinants of health. In earlier presentation, we see the commercial determinants of health. Our health strategy plan also has explicitly mentioned the wider determinants of health. This is how the paradigm of health systems or health policy dynamics has been changing. And now there is a concept of the indigenous, determinants of indigenous people also. This is how socio-cultural determinants and all other wider determinants are taken into consideration. In the last, I would like to conclude that health, illness, disease, therapies, and the medical care or medical practices that we are facing or we are experiencing, these are socially embedded, these are socially produced and reproduced, and we need to take a closer look into it. Thank you very much.
Okay, thank you, Mr. Javinder sir. Next presenter, I would like to invite Mr. Susan Karki, who is the public health professional from Nepal with the experience of more than 20 years, and he has a master's degree in public health, MPhil in population studies, as well as he's a PhD pursued and from Thailand. You can please.
Thank you, Chairs. Namaste. Yeah, I'm going to present here based on secondary analysis of demographic health survey from 1996 to 2022. That means it's about the 6th round of demographic and health survey. And for trends, I'm presenting here from each round of the demographic health survey, and in inequalities, I'm presenting here about the wealth inequalities and the caste and ethnicity-based inequalities. This is then your health facilities delivery means it's regardless of private or public, regardless of tertiary or primary facilities. And I think we know that there are more than 850,000 pregnancies occur every year in Nepal, and about 50% ended in live births, and more than half remaining those pregnancies are ended in either in spontaneous abortion or induced abortion or stillbirth. That means institutional birth is very important here, and the literature, various literature suggested that the health facilities during childbirth is important to reducing maternal and child morbidity and mortality. And here, this literature suggests that wealth status and caste ethnicity are the major factors in inequalities in health facility utilization in Nepal. For this, this is the pathway of continuum of care, that is ANC, delivery, health facility, and PNC. I am talking here about the delivery at health facility. And the objective of this study is study gauges the trends of institutional deliveries in 6 round of demographic and health surveys, and assess the inequalities in wealth and caste ethnicity for institutional deliveries. This is straightforward objectives for my study here. And the methodology is very unique and different here, because you all know that the demographic health survey is the cross-sectional study, and I'm using here the 6th round of demographic health survey. You know that demographic health survey refer the live births of last 3 years or 5 years, and for in 1996 and the 2022 demographic health survey, the survey used the last 3 years births for preceding the survey, and other 4 round of survey used the last 5 years of birth. And the total sample size for the study is 18,742 with applying sample weight. It means that it's about 3,000 births for each round of survey. That is actually approximately. In some year it's more than 3,000, and some year is more than less than 3,000. And for data analysis, the trend analysis carried out for 1996 to 2022, and analyzed pattern of institutional delivery situation for wealth and caste ethnicity. And I used the concentration index to see the inequality among the wealth of women. I think most of us know that the concentration index, that means 0 means that is the perfect inequality, and the equality, and the positive CI towards indicates the utilization is more concentrated among higher quintiles, and the negative CI indicates poor inequality. Yeah, this is the trend of health facility delivery in the last 30 years. We can say this last 30 years because 1996 refers to the 3 years labor. That means now from 1993, and for 2022, that means it's nearly 3 decades of the data here. And we found that there is 7.5% of women received the institutional delivery in 1996. In 2022, it's the 78.9, it's about 79. That means 10 folds of institutional delivery increase from 1996 to 2022. We cannot refer this data with the published data in the Demographic Health Survey report, because I use this data for the woman, not for the live births, because live births is more than the woman, because I'm analyzing the data based on the woman, wealth and caste ethnicity. And the average for the last 30 years is 33.9, that is about 34% of institutional delivery, and 66% are the non-institutional delivery in Nepal. And for the wealth pattern, the poorest is 17.9% institutional delivery. It's among the 18,742. This data is for all round of survey, and for the richest is 64.6% for institutional delivery. This means there is still gap in the poorest to richest. There is inequality between the poorest to richest. We can say this is a significant inequality in the wealth quintile. I'm also using the multivariate analysis here for the wealth quintile and for caste ethnicity analysis, but I am not showing here because of the time limitation. And for the caste ethnicity, you can see there is a significant gap in the receiving institutional delivery in women in the different caste groups, but the lowest institutional delivery in the Dalits community, and the highest in the other caste groups. That is also the higher group in the Nepal, that also based on the SDI, other things. And for the Brahmin and Kshatriya, it's also about the 40%. And it means there is still there is the gap, inequality in the different caste groups in Nepal. This is the concentration index based on the each year of data. In 1996, that is 0.54 CI value. That means the highest inequality in the 1996 and the lowest inequality in the 2022. Still 0.081 is the significant inequality in that year or two. For conclusion and the way forward, the institutional deliveries have increased by more than 10-folds in 2022 from 1996, but there are still 1/5 of women who do not have access to health facility delivery in 2022. And the inequality significance persists in institutional deliveries in Nepal, and the way forward in the it's like the previous colleagues also said that there is the blanket approach for all of the institutional delivery or for the utilization of health facility, and the blanket approach is not good for the reducing the gap for the institutional delivery. That's why it's we have to emphasize strengthen institutional deliveries for the specific target group based on the poverty or wealth index, or based on the caste ethnicity group. I think I complete my presentation. Thank you.
Thank you, Susan Karkiji. हाम्रो अर्को प्रेजेन्टेसन अनलाइन छ। दीक्षा छेत्री आईटी को साथीहरुले मद्दत गरिदिनु होला दीक्षा छेत्रीको प्रेजेन्टेसनको लागि। She is a skilled medical engineering professional with masters and medical equipment assessment, engineering design from Kelly University, UK. She has published numerous articles and focusing on equipment assessment, regulatory compliance, and other healthcare setting. IT, please.
Hello everyone, I'm Diksha and I'm truly honored to be here today to talk about a topic that I'm deeply passionate about and one that has the potential to create significant change. That is the development of affordable biomedical solutions for rural Nepal. Let's begin with a glimpse of the world we're dealing with. As you can see, the red dots represents regions with the highest child mortality rate. And if you look closely, you'll notice the green areas where the best healthcare technologies are concentrated. The disparity here is staggering. 90% of children die in regions where only 10% of global healthcare resources are concentrated. This is just one example of the vast inequalities that exist in healthcare access. Here's another picture that powerfully illustrates how mortality rates are linked to poor quality healthcare, and it speaks volume about the urgent need to address these gaps. Over 80% of medical devices are designed and marketed primarily for high-income countries, leaving 70% of devices in low-income countries like Nepal either non-functional or underutilized. This creates a significant disparity in healthcare outcomes, especially in rural regions. The gap between available healthcare technology and what is actually accessible to the people in these areas not only threatens health outcomes but demands an urgent, innovative solution. In Nepal, the problem is particularly acute. The country is heavily reliant on imported medical devices, many of which are non-functional or poorly maintained, especially in rural areas. These issues came into sharp focus during the COVID-19 pandemic, which exposed critical gaps in Nepal's healthcare infrastructure. Essential medical equipments like ventilators and oxygen concentrators were either unavailable or broken, which contributed to the loss of many lives. So how can we address this critical problem? That's where my study comes in. The study seeks to explore the feasibility of developing affordable biomedical devices specifically designed to meet the needs of the rural Nepal. It aims to investigate how local innovation, better regulatory structures, and supporting national policies can collectively reduce Nepal's dependency on expensive imports. By focusing on local innovation, we can enable the development and distribution of affordable, appropriate healthcare technology tailored by resource-limited settings. To address this challenge, I employed a qualitative exploratory research design based on secondary data analysis and comparative case studies. The methodology includes several steps. First, I conducted a systematic literature review to gather insights from academic sources and regional reports focusing on Web of Science and Google Scholar. Second, I performed secondary data analysis utilizing publicly available data on Nepal's imports and local health expenditure trends. Third, I undertook case study analysis focusing on successful examples such as Bangladesh's low-cost medical technologies which were implemented successfully in similar resource-limited settings. Finally, I engaged in policy and innovation mapping, reviewing Nepal's existing policy on medical devices, which helped us identify key gaps in regulation and innovation. The findings from these research methods highlighted some striking insights. Nepal's growing medical device market remains heavily dependent on imports, making healthcare expensive and largely inaccessible in rural areas. For example, while the global medical device market was valued at $739.6 billion in 2023, this growth has not translated into affordable healthcare for countries like Nepal. The high cost of medical devices are further inflated by import duties, shipping costs, and local distributor margins. During the COVID-19 pandemic, the demand for medical equipment in Nepal surged, with imports doubling. However, a significant issue is that these devices often fail to meet the specific needs of rural healthcare settings. Even when equipment is available, it is often poorly maintained and there is lack of trained personnel to manage it properly. So the key challenges are import dependencies, the high cost of imports due to import duties, shipping, and logistics. Regulatory gaps. There is a lack of national regulatory framework for biomedical devices in Nepal. Rural impact. Medical devices are either inaccessible or non-functional in rural health posts and hospitals. However, despite these challenges, there is a ray of hope. Low innovations like the Nano Nani neutral warmer from National Innovation Center and the locust light source for laparoscopic surgery designed by undergrads from the College of Biomedical Engineering and Applied Sciences have shown that Nepal can indeed reduce its reliance on expensive imports. For instance, Nano Nani neutral warmer costs just $650, whereas imported alternatives are priced around $3,000. Similarly, the low-cost light source for laparoscopic surgery, developed for just $365, compares favorably with imported models priced at over $1,200. These innovations are not just cost-effective, they are designed to address the specific challenges faced by rural healthcare providers, such as limited infrastructure and budget constraints. Looking beyond Nepal, success stories from countries like Bangladesh provides valuable lessons. During the pandemic, Bangladesh developed low-cost oxygen concentrators and surgical device. This success was driven by strong government support, local manufacturing, and partnership with NGOs. Bangladesh has demonstrated that it is possible to create affordable medical device suited to local needs, and Nepal can follow a similar path by promoting local innovation, supporting manufacturing, and building public-private partnership. To build on the successes of these innovations, we recommend several steps for Nepal. 1. Promoting local innovation by investing in research and development and fostering partnerships between universities, research institutions, and local manufacturers. Number 2. Supporting local manufacturers by offering tax incentives and amplifying the regulatory approvals processed by locally made devices. Number 3, fostering collaboration with NGOs to provide technical expertise and funding for local innovation. Number 4, building capacity by training local engineers and technicians to design, manufacture, and maintain biomedical devices. Number 5, encouraging public-private partnerships to create sustainable environment for the production of affordable, high-quality medical devices. In conclusion, the journey to providing affordable healthcare in rural Nepal is certainly challenging, but it is not impossible. Through strategic investment in local innovation, regulatory support, and collaborative partnerships, Nepal can reduce its dependence on costly imports and improve healthcare access for its rural population. Just as Bangladesh has shown us, Nepal too can turn this vision into a reality. Thank you.
Thank you, Ms. Diksha. Next, I would like to invite Mr. Sampurna Kachapati. He is distinguished public health professional and research expert with doctoral degree in research methodology. And he has extensive experience in public health, data science, research, monitoring, and evaluation, as well as statistics. The floor is yours.
Okay, good afternoon and namaste. Welcome to my presentation. I am very thankful and grateful for NHRC for providing me the opportunity to present in this conference. So before I proceed to my presentation, I'd like to highlight that most of my former speaker and the present speaker say about urban health challenge, urban health problem, and urban health data. So on following those discussion, it is very important and imperative to design an urban health data portal that will integrate data from the different sources. So this brings to my presentation on designing urban health data portal in Buranikanta municipality of Nepal. So the Buranikanta municipality of Nepal. So this project seeks opportunity. This project seeks challenges into opportunity. So the urban health data portal design will integrate the data from the different sources that will be used by municipality to make the evidence-based decision making. now, okay. Okay, now I will discuss about the major urban health issue. Like in different countries, Nepal has also gone rapid urbanization. Because of rapid urbanization, there has been rise in mental health issue as well as environment health issue. The major mental health issue include the non-communicable disease, and the major environment health issue include the air pollution and waste disposal. Sorry, so this about my rationale. So there is a fragmented data source in the municipality. The municipality generally produce different type of data. Data arises from the water, data arises from the environment, data arises from the education, data arises from the health. But however, all these municipality generated data, but the data generated for the municipality do not talk each other. The data are working in the silo, and the absence of data harmonization generally impact the decision making. So it is important and rational to develop an urban health data portal that integrate all type of data, and the data can integrate into each other. So the objective of my study is first to analyze the urban health policy and the secondary data that exists within the municipality, and we will also identify and map the urban health municipality demographic detail, housing, socio-economic and health infrastructure. We will assess the all public health facility within the municipality, and we will also evaluate the prevalence of communicable disease, non-communicable disease, and environmental issue within the municipality. And finally, our objective is to develop to comprehensive urban health data hub for the municipality. So this is the resource method, how we are going to develop the urban health data portal of the municipality. So in the research method, we'll do formative research, like we do formative research on the municipality department, and we also do the social mapping. Social mapping will be done in the Ward 7 of the municipality of Braninkata municipality, and we'll do household census. Household census will be conducted in the Ward 4 and Ward 7 of the municipality, and we'll also measure the health facility. We'll also measure the availability and quality of all health facility of the municipality. And all this data will be used to develop urban health data portal. So about the research effort, we will conduct the formative research among the 4 key informant interview of the department of the municipality. So these are the department of the municipality where we conducted our formative research. The main purpose of the formative research is to identify what are the data source that are generated from the department of the municipality, what are the data constitution, what type of data are generated, and whether the data are used for decision making or not. So after the formative study, we'll also do social mapping. The social mapping will be done in Ward 7 of the municipality. So these are the indicators where we do the social mapping. The major landmark we'll collect were included education institutes, health facility, what are child development center, what are the green space, what are the blue space, what are the religious space, agriculture space. These are the indicators that we'll use for the social mapping. The main purpose of the social mapping is to identify what are the community assets and what are the resources available within the ward of the municipality. So another major component is to conduct the household census. So we are planning to do household census in Ward 7 and Ward 4 of the municipality, and the total sample on the Ward 7 is around 17,000 household, and in the Ward 4 is about 25,000 household. So the main purpose of the household census is to generate a comprehensive demographic, social, economic, and health profile. So another component of this household census is also develop a digital family health profile folder. So that will be a consolidated repository of family health profile. So the family health profile will include all detailed information of each family member of the household. So the another approach we are going to do is conducting the health facility assessment. We are going to collect the data of 11 public health facility of the Braninkata municipality. The major purpose of doing this health facility is to generate the availability of quality of resource health services within the municipality, whether there is available of basic service or not, whether there is available of medical supply or equipment or not. And besides this health facility assessment, we will also conduct the key informant interview among the key focal person of the health facility to identify what are the challenges, what are the issues, what are the barriers within the health facility. So this is the process of developing the urban health data portal. So how we develop urban health data portal is like we will collect the primary data. The primary data will come from the formative research, social mapping, household census, and the health facility assessment. All this data will be integrated into urban health data hub. And also we'll get the data from the municipality. All the municipalities have different type of data source. So all the data source available from the municipality will be integrated to include in the urban health data portal. And there is also, we also get the data from the secondary data analysis, like for the municipality we have the data of population census, and DHS data will also use that data to develop the urban health data portal. So in this way, we are going to develop the urban health data portal for the municipality. So this is the sample of the dashboard, like urban health data dashboard. This is also a sample. So this dashboard includes all the health indicator and all the information of each department. So this platform can be used by the municipality, whether which program to decide, whether for the resource allocation, whether which program we have to fund our resources. So this can be one of the interactive dashboard for the municipality. Besides this, this dashboard can be also interactive for the policymaker and for the planner, whether what type of data is available and what type of disease is burden within the municipality. So this is the major research activity we are going to do, and I'd like to inform that we have already completed some of the activity like planning and coordination, stakeholder engagement. Now we are in the phase of implementing of the research activity. And the end product of this project will be the designing the urban health data hub, and also we plan to use the urban health data hub for the decision making. So this is my conclusion. I would like to wrap up my discussion in the conclusion. Like the major finding, like urbanization in the municipality, urban municipality has faced complex health challenges, fragmented data source, and health inequality that need to be addressed. So we'll design this urban health data portal through the process of co-design and co-creation. It will create a platform that unifies data within the municipality, and that can help for the evidence decision making. And this is also an innovative approach which can put a municipality in the form of the digital transformation. This, so I like to end my presentation. Thank you so much.
Thank you. Thank you. ल सबै प्रेजेन्टरहरूलाई मुरी मुरी धन्यवाद। तपाईहरुले 1 मिनेट घटाएर हामी सुरु गरौँ है। 9 मिनेटमा भने असाध्यै मानिदिनु भयो है, हामीलाई सहयोग गरिदिनु भयो। त्यसको लागि सबैभन्दा पहिले प्रेजेन्टरहरूलाई धेरै धेरै धन्यवाद। हामीसँग धेरै समय छैन, तर 4-5 वटा प्रिसाइज क्वेशनहरु चाहिँ लियौं, छलफल गरौँ। हजुर प्लिज ask the very precise question to the precise person.
Thank you very much, and I really enjoyed all your presentations. So I'm Sangeeta. I'm a researcher, academic at University College London, and I was very interested in all your presentations, but particularly the photo voice. And so, being precise, I missed the alcohol presentation, but we're going to have a chat and talk about it later. Thank you. And as that, the photo voice, I've used it myself, and you know, I wanted to raise about ethics. You know, so you know, when you did the photo voice, did you give cameras to people, or did they use their own cameras? Was it their own phone? And also, I saw people, we could recognize them. There were some photographs of a person who was in distress, and they were kind of really wrapping themselves and sort of lying down. And the use, you know, involving images of people who are recognizable, even if they're not recognizable, even if you cover their face, you know where they work, you know, if they could be identified, do they know that
I think question
you're
is clear.
presenting? Yeah, that's the question. That was about the ethics.
Clear. Ethics, yeah.
Thank you, ma'am, for the important questions. First, I would like to clear out on ethics. So we have included ethical considerations in our training, and in that aspect, we covered the part of like ethical consent from the participants. First, we asked them to take ethical consent from the participants while they are taking photos. And we have also asked them to take written consent when they are capturing photos of the people, like from that, if their face is being identified clearly. And in other cases, like if face is not identified clearly, and we don't take the written consent, but we take the verbal consent on that issue. I don't know if I clear your question out. And in your next questions, like for the photography, they have used their own cameras from mobile phones or that things. So I would like to clear out on this. They have used their own mobile phones, and they capture their photos from their mobile phones. And we have like included in our protocol that if they have not their own smartphones, then we will provide them cameras. But in this case, in our research, they have their, all of the participants, they have their smartphones, and they use their own phones for capturing the photos.
Let's take the next question.
Okay, thank you, ma'am.
Thank you. Thank you.
Hello everyone, my name is Shrestha and I'm from Possible. My question is to Seethuji as well regarding the photo voice. What are the challenges did you face while using this technique, and how did you mitigate them, and how were the data analyzed? Yes, these are my questions.
Very short and sweet. Yeah, please.
प्रश्नको लागि धेरै धन्यवाद म्याम। च्यालेन्जेसको कुरा गर्नुपर्दा चाहिँ यो पार्टिसिपेटरी रिसर्च मेथड चाहिँ अलिकति च्यालेन्जिङ पनि हो, किनभने हामीले उहाँहरूकै पार्टिसिपेसनको थ्रुबाट चाहिँ इन्फर्मेसनहरू, अब फोटो भोइसको कुरामा चाहिँ फोटोजहरू लिने हो, अनि हामीले उहाँहरूलाई चाहिँ ट्रेनिङ दिँदाखेरि पनि अलिकति फोटोग्राफीमा पनि अलि इनडेप्थ ट्रेनिङ, अनि उहाँहरूलाई चाहिँ प्र्याक्टिस गर्न लगाएर त्यसरी चाहिँ गऱ्यौँ। अनि अलिकति थिम्सहरूको कुरामा हुन त हामीले उहाँहरूकै डिस्कसनको थ्रुबाट चाहिँ थिम्सहरू आइडेन्टिफाइड गरेका थियौँ होइन, तर पनि अब कुनै कुनै केसेसमा चाहिँ पार्टिसिपेन्टको लेभल अफ नलेज होइन त्यो कुराले पनि म्याटर गर्ने जस्तो लाग्यो। अनि कसैको लागि चाहिँ अलिकति बुझाउन गाह्रो भएको हो कि उहाँहरूले थिम नबुझ्नु भएको हो कि भन्ने कुराहरू चाहिँ हामीले पाएका थियौँ। जस कम्युनिटी पिपुलसँग चाहिँ अब स्पेसली मार्जिनलाइज पपुलेसनको पिपुलहरूसँग चाहिँ काम गर्न अलिकति च्यालेन्जिङ पनि छ, तर त्यसलाई कसरी एड्रेस गर्ने भन्ने कुरा पनि अलिकति प्लान गरेर।
थ्याङ्क यू। थ्याङ्क यू डाक्टर सुशील।
No, I appreciate all the presentations, beautiful. And I have a colleague who I work with very much closely, Achyut, and fascinating presentation really. And I have a few questions, particularly I'm pro-urban. So looking at the urban data across the three, तपाईँले जुन तीनवटा डोमेनमा हेर्नु भएको छ नि, धेरै जसको नोसन कस्तो छ भने urban population is more affluent compared to the rural urban नि, तर तपाईँको स्टडीमा चाहिँ केही rural area र urban area को comparison हेर्दाखेरि जुन province wise लामो लिस्ट थियो त्यो हेर्दाखेरि चाहिँ it's quite interesting. I'm trying to draw a policy message which possibly changes the discourses, policy discourses that are currently outlined in the context of Nepal, the way urban is presented compared with the rural. Any messages you want to draw and the policy landscape change looking at your results?
म यसलाई ब्रिफली मात्रै गरेँ किन भन्दाखेरि अझै एनालाइसिस चाहिँ अनगोइङ छ, कम्प्लिट पिक्चरमा हामी आइपुगेका छैनौँ। एउटा मैले देखेको पावरफुल पोलिसी म्यासेज भनेको चाहिँ हामीले जुन ब्ल्याङ्केट एप्रोचमा इन्फ्रास्ट्रक्चरहरू सेटअप गरिरहेको छौँ, जस्तो त्यहाँनिर प्रोभिन्स, अर्बन रुरल सेटिङ र पोभर्टीलाई हेर्ने भने सबैभन्दा पछाडि परेको सेगमेन्ट अफ पपुलेसन चाहिँ बागमतीको रुरल पुवर्सहरू नै थियो, जबकि बागमती क्यापिटल सिटी होस्ट गर्ने प्रोभिन्स हो होइन। त्यो हिसाबले हेर्दाखेरि अलिकति हामीले जुन हिसाबले इन्फ्लुएन्स ड्र गरिरहेको छौँ वान भेरिएबल एट अ टाइम डिल गर्ने हिसाबले, त्यो चाहिँ अलिकति मिसलिडिङ हुन्छ कि भन्ने हो। अर्को चाहिँ अर्बन रुरल क्लासिफिकेसनमा हाम्रो पारसीको अर्को प्रेजेन्टेसन थियो, त्यो चाहिँ हामीले डेरुगाको डिग्री अफ अर्बनाइजेसनको रिपोर्टसँग कम्बाइन गरेर अर्को एउटा एनालाइसिस गर्दैछौँ, सायद त्यसले चाहिँ बेटर पिक्चर दिन सक्छ अर्बन रुरल सेटिङको केसमा चाहिँ।
थ्याङ्क यू। डाक्टर वामदेव। अब एउटा मात्रै लास्ट कोही हुनुहुन्छ?
Hello. I have a very short question to Sujan Karki. Yeah, we know that Dalit and poor have limited access to health facilities, and of course limited access to skilled birth facilities. Do they have better access to traditional midwife or Subedi? Do the poor have better access to traditional midwives or Subedi?
Thank you, sir, for the question. But my study is focused on health facility delivery, and I have another same type for skilled birth attendance. But I'm not answering here about the Subedi because I'm just looking for the health facility delivery here. Thank you, sir.
Thank you. Thank you. Okay, this is the last question, and if we have some queries and questions, we will have that during our tea sessions. Thank you, please. Yes.
My question is for Ms. Preju. I'm not trying to provoke your results, let me clarify that. तर जुन वाइनसँग related there are few studies which are quote unquote said as good for your health because HDL good cholesterol जसलाई भनिन्छ त्यसलाई increase गर्छ भनेर पनि छ कुनै कुनै studies. Did you do some literature review on that, and did that impact anything with your results? किनभने तपाई त distillery मै direct गएर पनि कति interviews हरु लिनु भएको रहेछ हैन? Did that impact or did that come up or something?
Thank you so much for the question. Okay, so first thing, मेरो study को objective चाहिँ it was not specially focused on the alcohol अथवा health effect भन्दा पनि its major focus was on commercial determinant of health and how private sectors ले चाहिँ कसरी मान्छेलाई इन्फ्लुएन्स गरिराखेको छ त त्यो अनहेल्दी प्रोडक्ट्सलाई कन्ज्युम गर्नलाई भन्ने लाइनबाट चाहिँ गएको हो मेरो स्टडी. र अर्को कुरा अब यो हेल्थ हार्म्सको कुरा गर्ने भने इट इज डिबेटेबल भनेर भनिन्छ. जस्तै 1987 मा चाहिँ अल्कोहलको जुनसुकै अल्कोहल चाहिँ कार्सिनोजेनिक छ भनेर भनेको छ र WHO ले अलरेडी इभन अ ड्रप अफ अल्कोहल इज हार्मफुल भनेर भनिराखेको छ. अब यो त्यही भएर हेल्थ हार्मको डिबेटतिर भन्दा पनि मोर फोकस इज अन कमर्सियल डिटर्मिनेन्ट्स र हाउ आवर सिस्टम इन्टरेक्ट्स विथ इट भनेर हो. अब लिटरेचर रिभ्यूहरूमा त यो डिबेटेबल छ भन्ने कुराहरू देखिएको पनि छ, तर आई थिङ्क इट्स बिकज त्यो स्टडीको फोकस इज समवेयर एल्स.
Thank you. Thank you, Preju. Thank you. Yes.
Thank you so much. I'd like to thank all the presenter. उहाँले आफ्नो टाइममा आफ्नो नर्म्समा रहेर यहाँले प्रेजेन्टेसन गर्नुभयो. इन्ट्रेस्टिङ प्रेजेन्टेसनहरू थियो 10 वटै र सम्पूर्ण अडियन्सहरू यहाँलाई पनि धन्यवाद दिन चाहन्छु. ओभर टु यु सर.
थ्याङ्क यू. तपाईहरु सबैलाई धेरै धेरै धन्यवाद. हामी इनइक्वालिटिजको इस्युहरूबाट कुरा गऱ्यौँ. सोशल डिटर्मिनेन्ट्स, कमर्सियल डिटर्मिनेन्ट्स अफ हेल्थको इनइक्वालिटिजको कुराहरू गऱ्यौँ र अफोर्डेबल टेक्नोलोजीको कुराहरू गर्दै गर्दा डेटा हबहरू कसरी राख्ने भन्ने कुराहरू गऱ्यौँ. महत्त्वपूर्ण विषयमा छलफल गऱ्यौँ. त्योभन्दा अझ महत्त्वपूर्ण कुरा चाहिँ इन्टरसेक्सनालिटी हेर्नुपर्छ. तपाईहरुले अरू रिसर्च हेर्यो भने कहिलेकाहीँ हामी कास्ट सिस्टमको कुराहरू गर्दाखेरि दलित, अफकोर्स दलित एज मोस्ट मार्जिनलाइज ग्रुप इन नेपाल हामी हेर्न सक्छौँ डेटा इन्डिकेटरले. तर इनइक्वालिटी त्यो इन्टरसेक्सनालिटिजमा हेऱ्यो भने कहिलेकाहीँ बागमती प्रोभिन्सको दलितभन्दा कर्णाली प्रोभिन्सको बाहुन पनि गरिब हुन्छ. त्यो डेटाले देखाउँछ भने जस्तै केही तथ्याङ्कहरू आए, एकदम महत्त्वपूर्ण तथ्याङ्कहरू आए. त्यति महत्त्वपूर्ण तथ्याङ्क मात्रै आएन, उहाँहरू प्रेजेन्ट गर्नेले यसको पोलिसी इम्प्लिकेसन के हुन्छ, अब के गर्नुपर्छ भन्ने पनि तपाईँ हामीलाई झकझकाउनु भएको छ, आँखा देखाउनु भएको छ. निश्चय पनि NHRCले उहाँहरूको प्रेजेन्टेसनको सिन्थेसाइज गरेर केही न केही पोलिसी ब्रिफ निकाल्छ होला जस्तो लाग्छ. त्योभन्दा अर्को महत्त्वपूर्ण कुरा, ब्ल्याङ्केट एप्रोचले काम गर्दैन, कन्टेक्स्ट स्पेसिफिक प्लानिङहरू बनाउनुपर्छ भन्ने खालको महत्त्वपूर्ण एक खालको मेसेज तपाईँ हामीले पाएको छौँ. त्यो तपाईँ हामी सबैको लागि महत्त्वपूर्ण विषय हो भन्ने लाग्छ. जाँदा जाँदा एउटा भन्नु मन लाग्यो, कहिलेकाहीँ हामी धेरै कुरा गर्छौँ, एकाडेमियाले धेरै रिसर्च गर्छ, अरूले गर्दैन भन्ने कुरा। यहाँ दुईवटा लिडिङ अर्गनाइजेसनहरूले एकाडेमियालाई पनि च्यालेन्ज गरेको छ, एकाडेमियाहरूले पनि आफ्नो ऐना आफैले हेर्नुपर्ने बेला आएको छ। We have to think about that, which is very good message. Finally, NHRCले जुन प्लेटफर्म दियो हामीलाई यो चेयरिङ गर्ने, NHRC आइटीको साथीहरू सबैलाई धेरै धेरै धन्यवाद। अलि छुच्चो छु, केही भने रहेछ भने चित्त नदुखाउनुहोला। थ्याङ्क यू, थ्याङ्क यू।
Thank you, sir. Thank you to all our presenters for sharing your work with such clarity and dedication. Each presentation has offered valuable contribution to the ongoing discussion on the challenges and progress we are addressing in health inequalities and social development. To express our appreciation, I now request our session chairs to present tokens of gratitude to each of our presenters. As I call out the names, please come forward to receive your token of appreciation. Let us all offer a round of applause as each presenter receives their token. Ms. Preju Kandle. Mr. Achyut Raj Pandey. Ms. Sitashma Mainali. Mr. Vikas Koirala. Ms. Situ Keshi. Mr. Paras Mani Sapkota. Mr. Javinder Bhandari. Mr. Susan Karki. Susan Karki. On behalf of Ms. Diksha Karki, I request Dr. Rajendra BC to come up on stage and receive her token of appreciation. No, sir, Rajendra BC. On behalf of Diksha Karki. Mr. Sampurna Kakshapati. Thank you once again for your dedication and valuable contribution. Next, I would like to invite Dr. Hari Krishna Baskota, former Chief of Health, UNICEF, Pakistan, to come up on stage and present a token of appreciation to our session chairs for their outstanding leadership during this session. Please offer a round of applause to the session chairs. I now request all the presenters to join the dais for a group photograph. Please come forward. Thank you, everyone. Now that we have come to end of parallel session 8, I would like to extend my gratitude once again to our chairs, all the presenters, and the audience for making this session meaningful with your participation. We now have a tea and coffee break, and I encourage you to explore the poster presentation. Following this, we will continue with the panel discussion in Hall A, and we warmly welcome you to join us for this engaging session. Thank you once again, and we look forward to seeing you in next session. Have a pleasant evening.